Okay, let's get started. Good evening, everybody. This is Dr. Theodore Friedman, and we'll be having a webinar today on craniopharyngiomas and hypopituitarism. I'll mute everybody's phone when it's time for questions. At the end, we should have any time for questions. Please use the chat button. Craniopharyngiomas are an embryological tumor located in the hypothalamus or the pituitary, and I think it's important to recognize that it usually affects both the hypothalamus and the pituitary. They not only cause hypopituitarism, but also leads to damage of the medial hypothalamic nuclei due to the tumor development and its treatment. This often leads to hypothalamic obesity, and at least 50% of the patients experiencing intractable weight gain resulting in severe obesity. So this is the obesity issue, I think, is a crucial issue with the craniopharyngioma, and that's one of the reasons why I'm devoting my talk today. Hypothalamic obesity syndrome in craniopharyngioma patients is characterized by fatigue, decreased physical activity, uncontrolled appetite, severe obesity, and is associated with insulin and leptin resistance, which makes it harder to treat. Weight gain is one of the most distressing manifestations of hypothalamic injury associated with craniopharyngiomas. Some patients with craniopharyngiomas have weight gain and excessive eating, which is called hyperphagia, before surgery, but most get it afterwards, or most of the time it gets much worse after the surgery. So obviously patients with craniopharyngiomas need surgery, but the extent of the surgery often determines how much hyperphagia they get. And structural defects in parts of the medial hypothalamus due to surgery, radiation, or the tumor itself often cause uncontrolled appetite and rapid weight gain. And most patients with craniopharyngiomas get hypopituitarism, either partial or total. And the literature says, quote, despite optimal endocrine management, uncontrolled appetite and rapid weight gains are common. And I'm not sure all the patients get optimal endocrine management. So I'm going to talk today a little bit about craniopharyngiomas, but also about how to optimize the endocrine management in general with patients with hypopituitarism. So I won't dwell on that as much as some of my other lectures on hypopituitarism, but I'll really cater it to the craniopharyngioma patients, and especially the issues regarding weight gain and energy levels. The risk factors for developing obesity in craniopharyngioma patients include large hypothalamic lesions affecting several median hypothalamic nuclei, such as the arcuate nucleus, the ventral medial nucleus, and the dorsal medial nucleus. And also tumors that reach the floor of the third ventricle usually lead to more hypothalamic obesity, hydrocephalus, transcranial surgery, which often causes greater damage to the hypothalamus compared to the transnasal surgery that I think most surgeons are doing now. More aggressiveness of the resection, reoperation for tumor recurrence, and many patients have had more than one surgery, and hypothalamic irradiation can often lead to worsening obesity. There was an interesting study that used what's called functional magnetic resonance imaging. Subjects underwent first a functional MRI, received a high-calorie test meal, suppressed appetite, and had a second functional MRI after the meal. Before and after scans, hunger ratings were performed. Following the test meal, controls, normal people, showed suppression of activation in different brain regions related to appetite, while craniopharyngioma patients tended to have higher activation in these areas. So this preliminary data supports the hypothesis that perception of food cues may be altered in hypothalamic obesity, especially after eating. So somebody doesn't feel satiated after eating if they have hypothalamic obesity, such as in craniopharyngiomas. It's an interesting question, and I'm going to address this in my talk today. What gives the weight gain? And in general, weight gain is either due to increased food intake or reduced physical activity. And it's probably both in the patients with hypothalamic obesity due to craniopharyngiomas. One study suggests that the reduced physical activity rather than increase in energy intake in cranipharyngioma patients is responsible for the obesity development. So I think it's very important to, when you treat a patient, to optimize both hormones that would decrease food intake, but also increase energy, increase activity, which is probably related to your energy level. And this shows different areas of the hypothalamic nuclei that can be damaged in patients with craniopharyngiomas. The crucial nuclei are the arcuate nuclei, the VMN, the parvomagno nucleus, and the DMN. Different hormones involved include hypothalamic signals, obesity signals in the hypothalamus. They have receptors here: leptin, insulin, adiponectin, GI peptides such as ghrelin and PYY. In the hindbrain, there's different hormone receptors for CCK, PYY, and GL1. There's hyperinsulinemia, often due to disinhibited vagal nerve reduction, and reduced sympathetic tone. This would be the adrenaline drugs, catecholamines, leading to low activity and metabolic rate. There's possibly the hypopituitarism, including some of the hormones the pituitary makes, play a crucial role, and at least this author suggests here reduced alpha MSH activity. I'm not sure that alpha MSH is really that important peripherally. Centrally it is, but peripherally it's not, and it would be nice to have an assay, a good assay for alpha MSH. Alpha MSH is an important hormone in obesity, but the assays are really not good so far. All these together leads to this obesity that craniopharyngioma patients get. So this is a nice summary of some of the causes of obesity in patients with craniopharyngiomas. Decreased catecholamines, decreased physical activity, deficient melanocortin, which is the alpha MSH basically hormone signaling, extra leptin, hyperinsulinemia, hypopituitarism, hyperphagia, eating too much, and altered food reward. So all these can contribute to the obesity in patients with craniopharyngiomas, and hopefully can be targeted to try to decrease some of that. So some of the treatment for hypothalamic obesity, first of all, you would recommend, as most doctors probably do, diet and exercise. In general, craniopharyngeal patients and patients with hypothalamic obesity do not really have a success with diet and exercise, much less than a patient without that. But I would still recommend that in all the patients, is to try to eat as well as you can and exercise as you can. Again, most of these patients are very tired and sort of run down, low energy. It's hard for them to exercise, but with proper hormone replacement, they may start, but you should certainly encourage the diet and exercise. I think a promising area is bariatric surgery. There's very little literature on this. Trotta in 2017 reviewed 3 cases with a mean age of 22 that were treated for hypothalamic obesity, mostly due to craniopharyngiomas, with a laparoscopic sleeve gastrectomy. So this is one of the more simple types of bariatric bypass surgery. And these patients had a dramatic weight loss from 49.2 kilograms per meter squared BMI to 35.3. So this is a nice weight loss they had. And it looked like most of them sustained their weight loss. There wasn't any need to change hydrocortisone steroid dosing in these patients. In 2 patients, the dose of levothyroxine was decreased. And interesting, growth hormone replacement therapy was increased in 2 patients, where it was started in 1 patient. So I think, again, that bariatric surgery has a promising role in these patients, especially with optimization of the hormones. Another common drug you would expect to work is Ritalin, methylphenidate. And there was only 1 case report, surprisingly, of methylphenidate in a patient. This article then by Elfers and Roth did it in a mouse model that had hypothalamic lesions. And you can see over here, they're a little blurry, but the patients was started on a low dose or fairly medium dose. It's 10 milligrams in the morning, 10 milligrams in the evening. I'm sorry, 10 milligrams in the morning, 10 milligrams in the evening for a dose of 20 milligrams over here. Not much weight loss, and then the dose was increased to 30 milligrams in the morning, 10 milligrams at noon, and 20 milligrams in the evening. And the weight went down pretty precipitously over here. So I think Ritalin, methylphenidate is a very good choice to treat these patients with hypothalamic obesity and cranios. Much more literature should be done to look at this in a controlled fashion. There's a drug that used to be on the market called sibutramine. It's also called Meridia. It was pulled from the market a couple of years ago because of side effects of heart disease. I think this drug is somewhat similar to in mechanism to the drug that is widely used called phentermine, and I think there should be a study looking at phentermine in these people with hypothalamic obesity. This study here took 50 children aged 7 to 20, included 22 with hypothalamic obesity and 28 with uncomplicated obesity, plus aggravating symptoms. The drug sibutramine led to a modest weight loss. It was very hard to tell the way they presented the data, how much pounds or kilograms it was, but looking at the graphs, it didn't look that much, but it was somewhat effective. And the response of children with hypothalamic obesity was significant, but was less pronounced in the children with non-hypothalamic obesity. Again, this idea that patients with hypothalamic obesity, it's sort of harder for them to lose weight than another child equivalent with regular obesity. But again, drugs, I think, that affect your food intake, this one again is pulled from the market, but these drugs should be studied more and may be used in certain patients. And now I'm going to talk, lead into the talk about pituitary hormone replacement in patients with craniopharyngiomas. And I'd say the two key things when you replace a patient with hypopituitarism is to minimize the weight gain and maximize the energy. Someone has more energy, they'll exercise more, they'll feel better, they'll eat better. So I think those are the two things. And I guess another thing would be to try to improve their sleep, and that will also make them feel better. So different hormonal axes, most of these are pretty affected in patients with cranials. Most of them have fairly complete hypopituitarism. The hormone axis that's the most well preserved, but still many patients with craniopharyngiomas have a defect in this, but not all. And I see some patients that have been on cortisol and we could take them off of it. So each of these axes has to be assessed separately and has to be treated. The first axis is the CRH, ACTH cortisol axis, with cortisol as the end product. The second axis is the thyroid axis that has TRH, the hypothalamic hormone, TSH, the pituitary hormone, that makes T4 and T3. You have the gonadotropin axis that makes GnRH from the hypothalamus, that makes LH and FSH in the pituitary. These have to be secreted in a pulsatile manner, and these leads to testosterone and estrogen. You have the growth hormone axis. That's GHRH in the hypothalamus, growth hormone from the pituitary, and IGF-1 is the peripheral hormone that does the effects of growth hormone. And interesting enough, you also have the posterior pituitary hormones, and I gave a webinar a couple months ago on these, so I will go over these somewhat again, but I think these are crucial. Most patients with craniopharyngiomas also have a defect in these hormones, unlike patients with regular pituitary hypopituitary basis for hypopituitarism. These include arginine vasopressin, it's also called desmopressin, or AVP, and oxytocin, which I'll talk about considerably today. And there's an order of deficiencies, but most craniopharyngeal patients are missing all of them. Growth hormone is the first one to be affected. Gonadotropins, FSH and LH are the second one. TSH is the third one. ACTH is the fourth one. It can recover. Patients can have a defect in prolactin, which would probably manifest as inability to breastfeed when they after delivering a baby, and they could have defects in the posterior pituitary hormones. Again, most patients are missing a good portion of these, and not all of them. So I'm going to start with growth hormone deficiency. Growth hormone deficiency and its replacement, I feel, is crucial in craniopharyngiomas patients. Many of these are adolescents. They need this to grow. Growth hormone helps with energy, weight loss, sleep, mobility, mood. It's really a crucial drug for these patients. The dose of growth hormone for kids is based on their body weight, and it's usually a set dose for adults to start with. And then you need to titrate it based on the IGF-1. I would aim for an IGF-1 in the top of the range for someone's age. Side effects include joint pain and swelling, so if the child or the adult gets these side effects, you would cut down on the dose. The next axis I'm going to talk about is cortisol, and when I was at the NIH, Esteban did a study looking at how much cortisol is produced in normal volunteers using a stable isotope method, and he found that 9.9 milligrams per day, about 10 milligrams per day, or 5.7 milligrams per meter square is needed. Not all is absorbed, so the average replacement dose is 12 to 15. Most patients get too much glucocorticoids. Too much glucocorticoids leads to weight gain, and again, our whole purpose here is to try to eliminate the weight gain. Also leads to osteoporosis, glucose intolerance, or diabetes, and increased infections. I think you have to hit a sweet spot with a cortisol replacement. Too little, because they feel pretty tired, they run down, likely a chance of getting adrenaline deficiency. Too much, and they get these side effects. So if you have a proper replacement, it's pretty benign, and they're likely to do well. Usually don't get these side effects. But again, you have to try to figure out the right dose for people with hypopituitarism. Many patients are overtreated. Some of the early manifestations of excess treatment is easy bruising, weight gain, central obesity. One of the earliest manifestations of inadequate treatment is joint pain. And it's reasonable to mimic the circadian rhythm with most or all of the cortisol given first thing in the morning. And you want to avoid nighttime administration that could lead to sleep disturbances. I did a study when I was at the NIH in 2000 that patients need a little bit of cortisol at night to go into deep sleep. So I usually recommend a small dose, 1.25 or 2.5 milligrams of hydrocortisone at night. And I think, again, optimizing sleep is crucial for these patients. There's no study that compares different treatment regimens. My approach is usually to give most of the hydrocortisone in the morning, somewhere between 10 to 20 milligrams a day in a woman, slightly higher in a man. You can decrease slowly until some symptoms develop and go back a dose. Small changes make a big difference. With illness, I usually recommend increasing the dose. Short term, it's better to give a little bit more. Longer term, it's better to give a little less. And one can take a little bit more, 1.25 milligrams or 2.5 milligrams before exercise. And hydrocortisone and cortisol replacement is such a crucial hormone. Some patients just don't do well on it. There's other options, prednisone, Medrol, dexamethasone, or 3 of them that I use in several patients. And it's worth considering another hormone like these if the hydrocortisone is not working. How do you monitor glucocorticoid replacement? Signs and symptoms are the key ones. We talked about, so looking out for weight gain, bruising for too much, joint pains, nausea, vomiting, diarrhea for too little. I find a 24-hour urine for 7-10-hydroxysteroids is quite helpful. You want that in the normal range. Most of the assays, it's 2 to 6 per day. So if that's in the range, that's a good sign. Urine-free cortisol tends to be a little bit higher during replacement. And this is because most of the urine-free cortisol excretion occurs right after taking the cortisol. When you get to high doses, they're not bound by cortisol binding globulin and exceeds the reabsorption of the kidney. So sometimes it's higher because of it's being just secreted right after the patient takes the morning cortisol dose. The 17-hydroxysteroids you can also correct for creatinine excretion in grams per day, reflects cortisol metabolism, and is more integrated throughout the day. The next axis we're going to talk about is central hypothyroidism, and most patients have central hypothyroidism. I'm not going to go into the diagnosis here, but there's different options. You can do LT4 alone, levothyroxine, Synthroid, Levoxyl, tyrosine, Unithroid, T3 alone. I find that T3 doesn't get it, and there's literature supporting this, doesn't get into the brain that well. You can do T4, T3 combinations. You can use desiccated thyroid. The brand I use frequently is called WP Thyroid. There's Nature Thyroid, Armor, IRFA. These all come from pig thyroid. They're well processed. They're pretty consistent in their dosing. They're very good products that I think some of the mainstream endocrinologists try to give a bad rap to. You can take desiccated thyroid plus some levo LT4. And the proper treatment needs to be individualized. There's not one blood pressure medicine. There's not thyroid medicine. Multiple studies have shown poor quality of life among a percentage of patients on levothyroxine alone, and this may be due to about 16% of the patients have a polymorphism, which means a change in their DNA in their type 2 deiodinase that converts T4 to T3. This was published in 2009. These patients did better on a T4, T3 combination. What about desiccated thyroid? WP Thyroid and Nature Thyroid are made by RLC Labs. They're very well formulated. Right now there's a little bit of shortage of them, but I think that's going to be quite short term. They have minimal, especially WP Thyroid has very little binders or fillers. It has very little ingredients. I think it's more pure. Most patients like it a lot. It has desiccated thyroid in general, all the different brands have a higher T3, T4 ratio that human thyroid does. Most patients on desiccated thyroid alone would have a high free T3, a low free T4, and a low TSH. And because the levothyroxine, the liothyronine, the T3, has a short half-life, the LT3 and the desiccated thyroid should really be given twice a day. I think many people don't realize the importance of that. If you give it once a day, by the evening, your T3 is low. The next morning, it's really low. So it's best to give it twice a day. There may be other components of thyroid missing in synthetic preparations that's present in the desiccated thyroid. And sometimes, or most of the time, I give desiccated thyroid twice a day with a little extra T4 supplementation. And especially I use this in people who aren't doing that well on T4 alone. And I've been doing a little bit of work into this. I'm looking at the reverse T3. Some patients on T4 alone, and even a few on desiccated thyroid plus T4 can have a high reverse T3, which is an active hormone that blocks the binding of T3 at the receptor. So this happens. Again, it's not that common, but I look at it. I've been looking at it now most of my patients, and there may be a need to decrease the T4 or give more T3 if this happens. And in general, for hypopit patients, I aim for free T4 and free T3 in the upper normal range with a suppressed T3. And again, I think if you get to these values, the patients are going to usually lose a little more weight and have a little more energy than if these are lower. In general, I recommend taking thyroid medicine first thing in the morning on an empty stomach for the first dose. If you're on a twice-a-day dose, take the second dose in the mid-afternoon. You want to avoid taking with iron, calcium, vitamins that have iron or calcium, proton pump inhibitors like omeprazole, paraffin, bisphosphonates, orlistat, cholestyramine, all these. There's a minor effect with soy. I don't think it's that much, but it's probably better to not take it with soy products also. Most patients with craniopharyngiomas need sex hormone replacement, estrogen, and testosterone. Younger women who are hypogonadal are more likely to benefit from estrogen replacement probably than a menopausal woman, and I think especially for their bone health, it's important to put the younger patients on estrogen. Younger women feel better on higher estrogen preparations and should require higher doses of estrogen than postmenopausal women. Now, most importantly, and I'd say this is probably one of the key things that I think most doctors don't understand, oral but not transdermal estrogens inhibit the action of growth hormone in the liver. This leads to higher growth hormone and lower IGF-1 levels. The lower IGF-1 is really what you're trying to do. The higher growth hormone may make you more prone to getting diabetes. So I would avoid oral estrogens or birth control pills for patients on growth hormone. Let me just repeat that. Avoid oral estrogens and birth control pills for patients on growth hormone. There's estrogen patches, Climera, Vivel, there's generic ones. There's Estrogel, which is a cream. It's very good. You can get that from a compounding pharmacy in Canada pretty cheaply. I can give people the information about that when they come see me. Titrate the dose of the estradiol so it's the upper range for the follicular phase, usually about 50 to 100. In women with a uterus, you give progesterone. Prometrium is the brand I usually like the best. And sometimes this gives a little weight gain. It is sedating, so I give it at night. But if you're concerned about the weight gain effects, you can give it every 3 months, and that should be enough to induce a period. And most importantly, if a woman stops oral estrogens or birth control pills and stays on the same dose of growth hormone, her IGF-1 will usually rise dramatically, and she will likely get hand swelling and joint pain. So you have to do everything sort of slowly. Androgen replacement in men. Most men with cranios and other forms of hypothyroidism need testosterone. Symptoms of low testosterone include low libido, erectile dysfunction, fatigue, decreased muscle mass, and gynecomastia, which is breast tissue enlargement. I usually measure the free by equilibrium dialysis and the total testosterone levels. If the total is less than 200, it's likely. If 200 to 350, it's borderline. Again, many patients will do better on that. The free, again, if it's below the range, is usually a good candidate for replacement and doing well. LH and FSH are usually low. It's only helpful to really exclude primary hypogonadism. I think in these populations that most people expect to have pituitary basis of their hypogonadism, so it's not really needed. The best option for testosterone treatment, I feel, is subcutaneous shots in the stomach, either once or twice a week. But it usually doesn't get absorbed that well, especially in obese males. The levels don't go up. The shots, especially in the stomach, go well. You can do the traditional IM shots in the buttocks, but it hurts much more. It's more difficult, but shots in the stomachs are very easy. And I have a YouTube on, if you look up testosterone, Theodore Friedman, on how to give testosterone. It does not cause testicular shrinkage, so it's being used. I often use the HCG in combination with the testosterone shot. And for muscle energy, we switch to a patient or a cranial patient that try to optimize their energy. I usually aim for total testosterone or free testosterone level in the range. Typical dose is 50 milligrams twice a week subcutaneously. You can give an androgen patch, 5 milligrams. You often need at least 2 patches. A lot of skin irritation occurs. And you can give androgel. There's pumps and packets and stuff like that. They also often need a higher dose in patients that are pretty overweight to get good levels. The question about androgen replacement in women, patients with hypopituitarism have low testosterone levels due to low LH, which affects the ovaries, and low ACTH, which affects the adrenals. You can measure testosterone and bioavailable testosterone by a good laboratory. Can look for the a clue to hypopituitarism. It sort of says, do these patients need it or not? And I would say the bioavailable testosterone is more accurate than the free testosterone in women. And I recommend testosterone replacement in a woman with hypopituitarism with a low level with a testosterone cream. Compounding pharmacies have reliable and safe preparations. And almost all my patients treated with testosterone cream, they go from a low testosterone level to a high normal one with minimal side effects. The side effects includes acne, extra hair growth, rage, oily skin. Don't happen too often, but you have to watch for them. And the testosterone also can raise your IGF-1. Diabetes insipidus is also quite common in patients with craniopharyngiomas. It's marked by excessive urination and thirst. Usually most patients are on this by the time they come see me, but if there's a doubt, I have the patient collect the 24-hour urines and measure the volume. A volume greater than 3 indicates diabetes insipidus is likely. And then I have them do a 12-hour fast with no water and collect at 8 a.m. serum and urine osmolality in an AVP level. And having a high serum osmolality greater than 300, a low urine osmolality less than 500, and a low AVP level less than 1 is usually indicative of diabetes insipidus. And usually this old-fashioned, I don't think you'll do it anymore, formal water deprivation test is not needed. Replacement, I usually give DDAVP pills. I think they're better absorbed. Some patients like the nasal puffs. Some endocrinologists like it. It works a little faster. I would have patients take most of their dose at night to prevent waking up at night. You need to have some kind of breakthrough period of urination where you're urinating out a lot of your urine. I try not to have them do that at night, more like in the evening of the next night. They should be urinating a little bit more. And the treatment is pretty benign. Most patients can sort of titrate the dose based on their urinary frequency. Okay, next we're going to go to oxytocin. Oxytocin is made by the posterior pituitary like AVP. It's really the only prominent pituitary hormone that's not tested or replaced. It may have a role in bonding, intimacy, orgasm, GI issues, trust, generosity, pain, and energy. There is a 24-hour urine oxytocin assay commercially available at Meridian Valley Labs. I try to get information on the reliability of the assay, and the lab wouldn't give it to me. I think it's okay, but I'm not sure how great it is. But I do recommend testing your urine for oxytocin with this assay. The supplementation for oxytocin is available from several compounding pharmacies as either sublingual tablets or nasal spray. And during the chat session, people can give me their opinions about if they're taking it, nasal versus sublingual, where they get theirs from, and what they think about it. I give patients a questionnaire for to complete about oxytocin deficiency, and I'd like them to complete it before and after the oxytocin administration. And I'd like them to get their labs done at this Meridian Valley lab for oxytocin both before and after their treatment. And I would say the patients that I treated with oxytocin, especially in the craniopharyngioma patients, have done quite well. And maybe some people, including Eugenia, can sort of mention what their experience is during the chat, but I think in general it's been quite favorable. The dosing can be tricky. A higher dose doesn't necessarily mean it works better. Kids often need a lower dose. And we need to adjust the doses based on the symptoms a little bit. If you're an established patient of mine, I'm happy to give you oxytocin. If you're not an established patient and wanted, you have to set an appointment with me, and we can evaluate you for it. Oxytocin does interact with other hormones. Oxytocin therapy decreases serum cortisol levels. This is a paper published in 1988. Many of my patients find that the cortisol requirements go up when starting the oxytocin. Some of the weight loss effects may be from lower cortisol levels. Oxytocin has been shown to support thyroid function by improving the import of iodine to thyroid cells, although I don't think this is clinically important. In a paper in 2011 in menopause found that topical oxytocin therapy helped treat vaginal atrophy. I'm going to try to summarize a little bit of the papers on oxytocin that came out recently. There's very little literature on it. There's this article by Coopins in Clinical Endocrinology of Prader-Willi syndrome. Prader-Willi syndrome is not craniopharyngiomas. It doesn't usually have a lesion, but it does have a lot of similarities, I think, to craniopharyngioma patients and hypothalamic obesity, as these patients have horrible satiety, behavioral phenotype with stubbornness, temper tantrums, manipulative, controlling behaviors, and obsessive compulsive features. Prader-Willi syndrome is associated with hypothalamic and oxytocinergic dysfunction. They did a crossover interventional study where they gave daily intranasal oxytocin and placebo administrations during 4 weeks in 25 children with Prader-Willi syndrome, ages 6 to 14. Overall, there was just a little disappointment, I'd say. In the total group, there was no significant effects of oxytocin on social behavior or hyperphagia. In the 17 children less than 11 years, parents reported significantly less anger, sadness, conflicts, and food-related behavior, and improvement of social behavior during the oxytocin treatment compared to the placebo treatment. The conclusion was that intranasal oxytocin administration has a beneficial effect on social behavior and food-related behavior in children with Prader-Willi syndrome less than 11 years old, but not greater than those 11 years of age. There was a recent study on the neuropsychological effects of oxytocin administration in child-onset craniopharyngiomas, published in Endocrine very recently in 2017. This was a single dose, though, a single administration of 24 units of nasally of oxytocin in 10 craniopharyngioma patients. And after the oxytocin administration, the cranial patients with the post-surgical lesions limited to the anterior pituitary showed improvements in emotional identifications, emotional issues, compared to the cranial patients with lesions in both the anterior and the posterior areas. This showed that the craniopharyngioma improved assignment to negative emotions. They were able to recognize they were having depression, and that this went up with the oxytocin. Another study published by Dubin-Bush in 2016 measured oxytocin levels in childhood onset craniopharyngioma patients. It measured the oxytocin levels in the salivary craniopharyngioma patients before and after a standardized breakfast. Patients that had a surgical lesion grade 1 in the anterior hypothalamic area had lower levels of oxytocin under fasting conditions compared to those that had a surgical lesion in the posterior hypothalamic areas grade 2 and those without hypothalamic lesions. So lower levels in a certain area. And they didn't do the study. This was just looking at the oxytocin levels. But they suggested that it should be explored as a therapeutic option in craniopharyngioma patients with hypothalamic obesity and or behavior pathologies due to specific anterior hypothalamic areas. That's basically my talk. I'm going to open up to questions, so I thank you for sharing your time tonight. If you have any questions, you can email us at Good Hormone Health. Go on my website. I do have an article on oxytocin for patients with pituitary dysfunction on my website, and I'll post the webinar in a few days. So let me open up the chat. Okay, does anyone want to ask any questions? So Kevin asked adult dosing for oxytocin. I usually start at 12 units 3 times a day. and either nasal or sublingual. Janet asks, what is the difference in somebody who has panhypothyroidism from cranial versus other causes? So the cranial patients usually have defects in their hypothalamus that lead to this hypothalamic obesity. They also usually have a more complete panhypothyroidism than somebody with a pituitary problem, although, you know, if you have panhypothyroidism, you really are missing all your hormones. But usually the cranials have more severe, missing more hormones, probably more likely to be oxytocin and vasopressin deficient. I would say that's the main difference. And then again, this hypothalamic obesity is somewhat unique to craniopharyngiomas and is a real challenge. Other questions? Janet also asks, I haven't heard of topical oxytocin. I haven't heard of that either. I usually give it nasally or sublingual. Most patients seem to like the nasal better, but again, there's some controversy on that. Ed asks, we live in Rochester, New York. Do you work with patients long distance? I need to see you first in person or your child, and then I can follow up afterwards by email or phone or FaceTime, but I do need to see you in person once due to my malpractice. I'm not really sure of people in the East Coast that are working much with oxytocin. Dr. Lawson, Lawson, in Boston, is doing a study on it, oxytocin. She might be a person to discuss. Marcy asks, what is a good starting dose for oxytocin for a child with hypothalamic obesity? I would say probably about 3 to 6 units once a day or twice a day, and you can then go up. Eugenia, if she's on the chat, maybe she wants to answer that question also with her child. We struggled a lot with the dose until we finally had a sweet dose, and it really helped him. I think the children are harder to dose than the adults. Heike says the first oxytocin batch had antidiuretic effects, the second batch worsened symptoms. So oxytocin is similar to vasopressin. It has very similar amino acids, and it has some diuretic effect and maybe can reduce your DDAVP dosing. The second batch worsened her symptoms. It possibly means that either it wasn't compounded properly or that affected her cortisol, and we needed to adjust her cortisol. Shannon asks, in menopausal women, do you prescribe progesterone every 3 months versus daily? And I think it depends. So this talk was mainly geared to the patients with the hypothalamic obesity, that you're trying to do everything you can to decrease the obesity. Progesterone does often lead to a little bit of weight gain, although the cream is usually much less than Provera, the old-fashioned pill, and I would say Prometheum is somewhere in the middle. So in some patients, I want to try to minimize it, and I would give it only 3 months. That's usually enough to slough off the uterus and get a woman to have a period. So 3 months might be okay. In other patients, they seem to do okay on it, and we can give it daily. Mike asks, is it possible that a child would develop a need for oxytocin post-operative when they haven't previously needed it? Yes. So first of all, I think people don't really look for oxytocin that much. If the child starts becoming more withdrawn, socially isolated, not trusting people, I would say that would be a good child to test for oxytocin and then treat it. Liz asks, how can we reduce leptin levels, high leptin levels? Lose weight. So leptin is primarily made by fat cells, and it's high in obesity. If you lose weight, it comes down. There is also leptin resistance. It doesn't get into the brain well and doesn't signal the receptors. But other than that, there's really not much to do. I mean, some people have advocated, healthier diets, but there hasn't been any suggestions that really works. Have you found any other labs versus Meridian Valley labs for oxytocin testing? And no, I think they're the only ones that do it as far as I know. If anyone else has some thoughts, let me know. When reverse T3 is elevated, is it due to something current? What can cause that? Could it be due to low calorie intake for decades, even if not current? I found that in patients that were untreated with thyroid medicine, the reverse T3 was always normal. It was the patients that were on mostly T4 alone, sometimes T4 is plus the desiccated thyroid, that had the high reverse T3, and by decreasing the T4, increasing the T3, I was able to correct that. So I would say yes, that a low-calorie diet can do it, but I would say only currently. Kevin asked the pathophysiology of peripheral edema and oliguria during high heat or overexertion. I'm not sure I know the answer to that question. There's some there's this idea about idiopathic edema I used to look at a lot when I was a fellow about 25 years ago. I don't think people are doing much work on it. It may have to do with dopamine levels now. And also, some people that have, low albumin, they third space, they get fluid in their outside of their blood vessels. The treatment would be, the stockings, for example, try to avoid the high heat or overexertion. Patricia asked, my doctor will now explore oxytocin replacement due to lack of studies. Is there a good reason that I can give her? I think she's right. I think there is a lack of studies. And many doctors like studies. I like studies too. I think that's where hopefully I'm sort of a little different than your average doctor, because I do try to look at the studies and that are there. And again, there's not many of them. And try to think that is this going to be the benefit versus risk for my patients. And so far, my patients have benefited from it. So, I think you'd be a good person to come out and see me. Heidi asked, taking estrogen, progesterone, testosterone, DHT, and cream compounded, no periods, that is normal with menopausal. Yes, I would say that's normal. To get a period menopausal, you have to cycle your progesterone. Most menopausal women don't want to cycle it. They don't have a period, so I give it continuously. But if somebody does want a period, then you need to cycle your progesterone. Patricia asks, is cream or patch estrogen better? And I would say they're both good. Again, avoid the oral estrogens. Both cream and patches are good. They have different pluses and minuses. The cream, people are worried if they have little children, they might get the estrogen cream on them. That's not good for children. Some people don't like putting the cream on every day. The patch is once a week or twice a week. You can have a little patch, the Vivel, or a big patch, the estrogen, the Chimera patch or the estrogen patch. It's once a week. Some people say it itches them, it falls off in the shower. So each of them has sort of pluses and minuses, and I think it has to be an individualized answer. It's also, insurances are getting very tough to cover the estrogel. I love the estrogel. Most insurances seem to deny it. Therefore, we get ordinated from a compounding pharmacy in Canada, and it's a good option if you want to get it from there. So I think the availability is an issue also. Mike, are you able to list any pointers in mid-teens children, other than you have already mentioned, that may suggest a lack of oxytocin? Currently medicated only on thyroxine HCH. So I presume you have a child that has craniopharyngioma that has surgery. So I would say the oxytocin would be the last to go, and somebody that's not on cortisol, testosterone, maybe vasopressin, maybe less likely. Again, and I think the issues would be the weight gain and controllable appetite, maybe erratic behavior, bonding problems, social isolation. I would say all those that would suggest a lack of oxytocin. Patricia's doctor also rejects the idea of replacing testosterone in women. Same reason, lack of studies. There are some studies. We did a study. We didn't finish it. We didn't really get enough patients in it to conclude. Karen Miller did a study in Boston about it, and it was beneficial. It wasn't that beneficial, but it was definitely beneficial. So you can show your doctor the study by Karen Miller about replacing testosterone. It did have some improvement. Or again, you can come out and see me. How likely are hypopit patients to regain weight after bariatric surgery? At what point should bariatric surgery be considered? That's a great question. So the studies that I showed, again, it was only a series of 3 patients. They were seen fairly early, and they did quite well. And I think at least one of them, they looked at it a little bit after the surgery. But I think that's always the question of bariatric surgery is weight regain. And the more extensive surgeries, the Roux-en-Y surgeries usually do have less weight regain than the sleeve surgeries. And I think at what point should it begin? I think it would be considered, I think if the child or the young adult is quite obese, has diabetes, for example, is not doing that well, diet and exercise in general aren't working that well, hormones are optimized already, I would consider it. And I think, I have several patients that had gastric bypass surgery. I have this one gentleman from, sort of near Los Angeles. He weighed, over 400 pounds. And, even if the best hormone replacement, he had hypothyroidism and hypocalcemia, even on the best hormone treatment, he's not going to lose that much weight. But he did the bypass surgery plus proper treatment, and he's lost about, 150, 200 pounds already, and he's doing great. Heike asked, when will the dual-release hydrocortisone be available in the United States? I'm not sure. I'm personally not a fan of the dual-release hydrocortisone. The dual-release hydrocortisone only comes in 2 doses, as I recall, 20 milligrams and 5 milligrams. And it's supposed to be the sort of delayed release. But I think the lack of dosing is a problem. And also, most patients, I think I can do pretty well in their dosing with either hydrocortisone or some other combination to give them the right amounts at certain times a day. And you have more flexibility with hydrocortisone that comes in multiple doses. Kevin's asked, average HCG testosterone combo therapy dosing in adult hypopit men. In general, I would probably do the testosterone about 50 milligrams twice a week. The HCG, maybe 500 units 3 times a week. And try to stagger a little bit the HCG from the testosterone so that sort of in a valley of the testosterone before the next dose, you get the HCG. Usually, you don't need too much HCG to restore the testis size, so something like 500 units 3 times a week would be a good choice for that. Thanks for the answers, Theodore, all the way from Melbourne, Australia. Thanks for joining us, Mike. Nice. My primary doctor prescribed phentermine after I read that they're using it again for weight loss and fibromyalgia. She doesn't like keeping the patients on it long term, but there's a study going now for long-term use. What is your opinion of phentermine? I think phentermine is a great drug. So I use phentermine a lot in my obesity patients in my county hospital. It works well in terms of decreasing appetite. It's inexpensive. It's pretty safe. And the side effects include keeping awake at night, insomnia. So most people, I started it on half a pill before lunch and dinner. But if you get insomnia, then I would move it to all in the morning. Some people get urinary retention on it, and also it doesn't work long term. So I think she's right on it, that usually it stops working after about 2 to 4 months. You need to either go on a holiday or try something else and then go back on it, and then it'll usually work again after a little bit of a holiday. So I think it's a good drug. Usually people get a little more energy on it. It's certainly a reasonable choice. And I think, the other thing I want to mention while waiting for other few questions, I'm glad there's a study on it. It's an old drug that's generic. There's no pharmaceutical company behind it, although there is a company that's making a low-dose one, which I don't see any advantage of it. The newer drugs, there is Belvix, there's Contrave, there's the GLP-1 drug. They're all, new drugs are a fortune. The pharmaceutical companies are getting a lot of money. Most insurance companies, thank you. They're really expensive, and most of the time the insurance doesn't cover it. And they try to give this little thing about giving out some samples. So it's for most doctors, I think it's just too much hurdles to try to put the patients on these drugs. So I think the phentermine is so much easier to give. It's less expensive. It's safe. It's been around for a long time. What are your thoughts on giving a growth hormone to a child who is pan-IFID but seems to be growing without growth hormone, but whose IGF-1 is low? I would probably certainly test that child. I'm not a pediatric endocrinologist. The pediatric endocrinologist has sort of different testing for growth hormone than adults do. But I would certainly test that child. It depends on how fast he's growing and what his parents' height and what's his predicted adult height. But I would think that child would benefit from some of the other effects of the growth hormone. What is the first hormone you look at in obese hypopit patients? How many patients expect to lose? How many pounds should the patients expect to lose on the current dose? So, I look at all the hormones basically. Every single one needs to be optimized. I'd say in general, most patients are not on enough growth hormone, not on growth hormone. They're on too much cortisol. They're probably not enough thyroid medicine. Many of them are not on testosterone. None of them are probably on oxytocin. So all those I really try to optimize in tandem, and then sort of adjusting, one, you have to adjust all the other ones and sort of keep an eye on things. Extra testosterone, proper thyroid dose, it helps some. I don't think it's going to lose a huge amount of weight, but the patients will feel better exercising more. So again, I would optimize everything. I had to ask, our adult son is dealing with apathy and anxiety. He's on full hormone replacement for 11 years. Could he oxytocin deficiency? Absolutely. He sounds like a perfect person for the oxytocin. The other thing that we've mentioned a little bit about is the stimulants, Ritalin. Ritalin, there's something called pituitary apathy, which is usually sort of like depression, but it's more apathetic. It's very common in patients with pituitary disease. I think some of it may be due to low growth hormone, although it may also be due to the oxytocin. And these patients respond much better to stimulants like Ritalin and not quite as much as to typical SSRIs like Zoloft or something like that. So I think Ritalin would be a good option for him, but certainly have him come see me for the oxytocin. And I'm not sure he might be on full hormone replacement, but whether he's on proper hormone replacement, that might be a different story. And I'm happy to evaluate him. You suggest an over-the-counter medicine to increase IGF-1 called Serovital. Does it work? If so, how? I think it works. It's amino acids that stimulate the growth hormone to secrete more growth, the pituitary to make more growth hormone, raise your IGF-1. I did get a fair amount of samples at my last Endocrine Society meeting from it, so I was going to try to look at it a little bit more systematically. But my feeling is it does work some. I would say it's not as good as growth hormone, but it does work some. And it's about $100 a month, so it's less expensive than the growth hormone, but not cheap. Kevin asked, with thoughts on modafinil in hypopit patients. Modafinil is a stimulant, but it's very good for narcolepsy. I don't think it works as well as the other stimulants like Ritalin or Adderall, is my personal thought, but it's an option. Liz asks, all hormones optimized so no weight loss. I think gastric bypass is certainly an option. Make sure your hormones are optimized. Consider make sure the growth hormone is there, as little cortisol as possible, and then come see me if you're not seeing me already. Any other questions? Final call for questions. What GI issues does low oxytocin cause? Sort of like an irritable bowel syndrome type of issues, sort of the bloating, alternating constipation and diarrhea, vague abdominal pain. I would say those are the most common ones that usually gets better with oxytocin. Any advice for anxiety or insomnia? So anxiety can be too much thyroid. Insomnia can be too much thyroid. Taking your medicines at night, your thyroid medicine at night can give you insomnia. Some people just need anxiety medicines. SSRIs are good for anxiety and for sleep, especially I like Zoloft at night. Buspar is good for anxiety. Other medicines, the medicines for overactive bladder, they give a lot of insomnia. So just make sure your medicines are good. You're not taking anything at night. You're not around. You don't have a lot of screen time at night. All those things. Okay, Brittany. I was diagnosed with growth hormone deficiency as a child. However, my insurance will not cover the glucose stimulation for adults. Only ITT. What are your thoughts on it? You know, I like the glucose test better. The ITT, you get hypoglycemic. Nobody likes getting hypoglycemic. Doctors don't like it. Patients don't like it. You might try to get your doctor to appeal to the company, your insurance company, that it would be better to do the glucose test. It's safer. But if you have to do it, you have to do it. I find that it overdiagnoses cortisol deficiency. I think it's pretty good for growth hormone, but probably picks up too many people that it says have cortisol deficiency that don't. Janet says, oxytocin is definitely helping me sleep. Excellent. Kevin says, iron deficiency and hypopituitarism. Iron deficiency in women is quite common. I don't think it's more common. It's probably less common in hypopit women because iron deficiency is usually due to too much your menses. And you have a woman that's 35. She's had periods since she was 12, 23 years of periods every month, a pint of blood every month. You lose a lot of iron. So a patient that's hypopit, that's unless they're back on replacement and a cycling, they would have less iron loss. That's in general my thought about it. Does CPAP treatment lead to weight loss in some patients? Does hypopit worsen sleep apnea? I'd say yes, CPAP does lead to weight loss because you're much more active during the day. You're sleeping better at night. You're active during the day. When you're tired, you eat worse. You eat comfort foods. You don't exercise as well, so it does help with the weight. It probably lowers your cortisol at night, so that helps. And does hypopit worsen sleep apnea? I would say probably also that in general, that you're more overweight, you're probably a little more, your tonsils are like more swollen, possibly. There is some studies that suggest that growth hormone and testosterone, too little can give you sleep apnea, but treatment can also make it a little worse, although I don't find that the case. I think if you optimize your hormones, the sleep apnea can improve a little bit. Dina says, how much is the usual hydrocortisone is required for a 60-year-old plus hypopit patient? My blood pressure keeps creeping up with increasing cortisol. I would probably try to use as little as possible. I don't know how much you weigh, but somewhere around 15 milligrams a day is probably a good dose, and split doses. If your blood pressure keeps going up, probably try to cut it down a little bit. Patricia says, you say as little cortisol as possible. My doctor doesn't test it. I am on 10 in the morning, 5 in the afternoon. Is this too high? Should I split 5, 5, or 5? I like 10 and 5. I would take your second dose around 2 in the afternoon. And, watch out for too little, nauseousness, vomiting, diarrhea, joint pains, too much, weight gain, bruising. So, but 10 and 5 seems reasonable. You can try the 24-hour urine. And I like taking most of it in the morning, so I like the 10 and 5. If you're having trouble sleeping, you can add a little bit at night, like 1.25 milligrams. Marcia says, how do you test if a patient really needs cortisol replacement? They've been on for years. So what I would do is I would have them don't take their cortisol 24 hours before their blood test. So let's say they get their blood test on a Monday. On Sunday, they take their morning dose, not their afternoon dose, not their morning dose on Monday morning. Get a cortisol and ACTH level, and then take your morning dose. If your cortisol is probably above 7 or 8 or so, you could probably taper off of it. If your cortisol is low, then you probably can't. So that's probably what I would start with. And if you can't do that tapering, you probably need to stay on it. But you could take dexamethasone the day before your test also, something like 0.5 milligrams, and get your cortisol drawn. So usually start with the cortisol measurement. Okay, and do hypopit patients on low-dose cortisol replacement need to stress dose when sick or surgery if they're still making some cortisol? Absolutely. So, when you're sick or surgery, the dose goes up much. And if you're taking just a little bit, low dose, you usually need a stress dose. Double your dose if you're sick. Surgery, it's usually like 100 milligrams before surgery, 50 milligrams afterwards. Let me know, and we can give you, depending on what the surgery is, let me know what you're doing, and we can give you a replacement. Heike asks, is it better to be on 10 milligrams hydrogen total and exercise every day, or take 17.5 and don't exercise, weight 133 pounds? I would take the more dose and exercise. Exercise is great. Everybody needs it. I think so. An older test has resurfaced to test cortisol deficiency. This is an overnight mature prone test. Stim test. Any thoughts on this? I'm not a fan of that one either. It usually makes people very adrenaline insufficient. I'm not sure. I haven't seen that much advantage of it over a costotropin test. It's hard to get in the United States, so I don't use it too particularly. Antidepressants for hypopit patients. So a lot of hypopit patients have this pituitary apathy that does better on stimulants, Ritalin and Adderall and the like. Patients with hypopit, obviously you optimize the hormones, thyroid, growth hormone can all help with the depression. And if they still have it, the Adderall is a good choice, Ritalin's a good choice, and then the SSRIs are good choices also, I would say. I think the SNRIs like Effexor and Cymbalta can also be used. Okay, so we're at 6:01. I hope everybody enjoyed it. I enjoyed this a lot. It was really good discussion. We'll end it here, and we'll call it a night. Lots of thanks from everybody. Thank you guys, everybody.